demonstrating ICP monitoring was one of the factors associated with better outcomes, overall in-house mortality, and decreased mortality due to herniation. So I think the overwhelming literature before the Chestnut study, which was published in the New England Journal, demonstrated that there was beneficial effects to ICP monitoring, and this was not on many people's radar screens before that paper came out. So the last argument I'll make to support my case, and I do believe we'll have disagreements based on the title of your first slide. I do think there are serious flaws with the only study that has suggested ICP monitoring was not useful. This paper again was the Chestnut paper published a few years ago, looking at patients in South America, taking groups of patients who they were able to do this study because the clinical personnel at the clinical sites had equipoise. They thought ICP monitoring was either good or bad. They didn't mind not putting monitors in for patients. So they had a group of patients who had an ICP monitor placed and a group that was treated with imaging clinical examinations, and found, again, about 300 patients total in this group. Interesting facts here is that mortality rates here, if you look at the third to last bullet point, the death rate was about 40% in each group, 39% in the ICP monitor group and 44% in the imaging group. This is extraordinarily higher than other contemporary studies in adult neurotrauma at the current time. Most clinical studies now have mortality rates around 20–25%, give or take. So this appears to me to be a very sick population of people, and if you look at their the baseline data they have from their patient population, it is. Other post hoc comparisons are that the imaging clinical examination group got way more ICP therapies than the ICP monitor group. So what effectively was happening in this study, and when you talk to the investigators, I'm not sure if Monica Vavalala is in the room yet or not, but if you talk to the investigators of this study who were there, it was basically people from South America calling Seattle to try to get them to figure out how to do this ICP monitoring protocol versus the imaging clinical examination group. And so whether there was just difficult communication or not, it's hard to know, but the ICP monitoring group got way less therapies than the clinical exam group did. So to conclude and get us back a little closer to time and get everyone closer to lunch, ICP monitoring, like all of the monitoring techniques, depends on the successful use of the monitor to obtain the best outcomes. And I would argue that rather than the device being the question, I think we should be testing protocols that treat ICP to see if which is more likely to determine how patients can do and to get the best outcomes. So look forward to hearing the rebuttal, and thank you very much for your time.
I think the Chestnut trial, it was not of, ICP monitoring is not of use. It is equally efficacious. Clinical monitoring is equally efficacious as an ICP monitoring.
That's correct, but a lot of people have interpreted the Chestnut article as that he proved to not do it.
That's not
right.
Exactly. I think after Dr. Michel, like, have you a change in consensus? How many people now feel that we should do ICP monitoring? You can't put up. Now, we have Dr. Matthew. I mean, it's just like you got married and you're advising another person why you should not get married. So Dr. Matthew has been a proponent of ICP monitoring for a long time throughout India. I mean, he was one of the first people to start it and use it extensively in CMC. So he will be speaking on against the motion, actually. ICP monitoring is not of use.
Okay, good afternoon for the second time. I have said this, and I've been quoted as saying this by several other people. So I start this debate at a slight disadvantage, saying, why would you treat raised ICP without measuring it? all right? Anyway, the thing is, when you put a BP cuff on somebody, there's not very much risk of doing this. And there's not very much risk of getting, devastating infections. So when we decide to do a therapy or a monitoring or whatever it is, it has to be based on risk benefit. And the best way of assessing that is if you have evidence-based studies. Now, a 2010 Cochrane database review on ICP monitoring said no studies meeting the selection criteria were there. There were no level 1 studies to say whether ICP is good or bad. So look, where do we go from there? It's very unlikely we're going to have a randomized controlled trial. I mean, like Dr. Michael said, the closest we came to it is the best trip, which has several procedural flaws. So there are studies. I mean, there are studies showing, excuse me, from the, well, there are studies saying that ICP monitoring is not good. All right. Two level 1 centers, one had ICP, one didn't have ICP. But there were several procedural flaws in this, which really made it not a viable thing to use. For example, the ICP patients who had ICP monitoring had a significantly higher incidence of hypotension in these groups. So obviously hypotension is one of the bad prognostic indicators for outcome from head injuries. So then the groups are not really comparable. AIIMS had a study, which Deepak Agarwal, I don't think he's still come here, is one of the authors, where the mortality decreased 8% with ICP monitoring, but there was no increase in the favorable outcome. This is the US in 2008, National Traumatic Data Bank, where they showed that there was 45% decrease in survival with ICP monitoring, which again, if you look at the study, read this paper itself, it reads wrong. It doesn't really prove anything. And that's the problem with most studies, actually, if you look at it, pro and against ICP monitoring. There are significant flaws. There are significant flaws in research design. They've got no controls. They've got historical controls. They've got some factors not accounted for. There is actually not available a convincing paper showing, listen, ICP is good. Even some of the trials that Michael quoted, I mean, New York, they had compared patients who had ICP and did not have ICP. Why did they not have ICP? What was the problem? They're not randomized to have ICP or not have ICP. Some had, some didn't have. Maybe there was some other reason behind it for them not having the ICP monitor put. And therefore, that might be the cause for your worse or better outcome, rather than the fact of having monitor or not having monitor. Brain Trauma Foundation again. Level 2 monitor for all abnormal CT scans. Level 3, which we've been following for a long time, isn't it? Age more than 40, motor posturing, systolic BP less than 90, 2 of the 3 present, measure ICP. If 1 or none are present, don't bother to measure ICP. Do you know that that data, if you read the paper, was 8 patients? 8 patients. Total of 207 patients. 61 had normal CT scans. Of the 61, 8 had raised ICP. So what we've been following blindly for many, many years is actually based on 8 patients. Okay? Our decision to monitor or not monitor ICP, probably hundreds or thousands of patients have been affected by this data from 8 patients. BTF also mentions in the thing that if you're going to do ICP monitoring, you have to remember there are costs involved, personnel, training, the cost of the personnel themselves, and risks. The other thing is the threshold. PTF level 2 is treat ICP more than 20. But old paper, 30 years ago, showed that if you bring the ICP threshold for treatment down from 25 to 15, you get a tremendous decrease. This is again a very, very quoted paper. Any paper on ICP monitoring does quote this thing. Again, if you look at it, there are 2 different time periods. They're not really comparable. 20, fine. But there's a paper, the first paper is without ICP monitoring. Temporal hematomas, it's logical. Temporal hematomas are much more likely to compress the brain stem than the something high up in the parietal region of the same size. And Marshall et al., the paper describing oval pupils, do mention a patient who herniated at an ICP of 18, accurate ICP. CPP, again, level 2, don't go aggressive to maintain CPP over 70 because of the risk of ARDS. Level 3, CPP target between 50 and 70. But if you think about it, 50 to 70 is a kind of, your normal mean is, if you take 120/80 as a normal BP, your normal mean is 93. So ICP should be what, up to 40 is okay? Okay? So otherwise, if you try and keep the ICP below 20 and your mean is 93, you've now reached 73 mean already, 73 CPP. And then you run into problems of autoregulation, and what happens to the patient, the patient who has impaired autoregulation and a high CPP, then what happens? Okay? So the point I'm trying to make is not that ICP is bad. It's just that we don't know enough to what is the correct ICP to treat, what is the correct CPP. We don't know enough. So not knowing what to do, are we justified in exposing the patients to risk without not knowing the numbers? Okay, I get this number of 18. Is 18 good for that patient, bad for that patient, or okay for that patient? I don't know. And therefore, am I justified in exposing that patient to risk? Risk of hemorrhage, risk of infection. Okay? And my other grouse, with this is for any kind of monitoring, is sometimes we get so caught up in the numbers and so fixed on our protocol based on numbers that if there's an error in measurement or there's a clinical deterioration, sometimes we forget about that and we just concentrate on the numbers. Best trip, this study, there were so many different interpretations of the study between the US and the South America, that they had this published, I think, 2 months ago in the NEJM, 1.5 months ago in the NEJM, which is 23 experts got together and made a consensus of what the best trip trial means. All right? And they all agreed that it is not a trial of ICP efficacy, not a randomized trial showing whether ICP is good or bad. That's not what it's supposed to be. It's just a comparison of two protocols, one ICP based and one image and clinical evaluation based. That's what ICE is. Okay? And the consensus was the primary impact should be on further research on how to select patients for ICP monitoring, how to set up ICP patient-specific ICP thresholds, and further evolutions of how to treat patients. It was not meant to be a comparison of ICP versus not ICP, which group of patients does better. And this one of the consensus statements is an 84% consensus among the 23 experts. It basically says that previously, imaging and clinical evaluation in a hospital that cannot do ICP monitoring because of limited resources leads to non-inferior clinical outcomes. Okay, that's what they say. That's all the claim they make. They're not saying ICP is bad, ICP is good, ICP is necessary, ICP is not necessary. In fact, if there is a further statement by Randy, what is his official name? I forgot. I call him Randy so often I've forgotten. Randall Chestnut. I've called him Randy all my life, so I forgot. Anyway, so Randall Chestnut, I have it on my laptop, I don't have it here, but basically saying that he would never treat a patient without an ICP monitor. Okay? He does not mean best trip to be a call to give up ICP monitoring, which is unfortunately happening quite often. Okay? He didn't mean it that way, but that's the way it's been interpreted. But what I'm trying to say is, if you cannot do ICP, it doesn't mean you're doing badly. Okay? Yeah, so I'll stop. I just say that there's no evidence, clear evidence that ICP monitoring improves outcome. Okay? There's nothing definite. And it's unlikely to ever be definite evidence without some confounding factor in it. And if you cannot do ICP monitoring, don't feel that you're giving inferior therapy. If you have good clinical evaluation and imaging available on call, your therapy is as good as with the monitor. Thank you.
Dr. Mike, please. Yeah, the topic of this meeting has been appropriately put, protocols to practice actually. I mean, 90% of us have read the protocols in the books, but when it comes to practice, it depends on a lot of factors, which we cannot follow a number of times actually. In our day-to-day practice, because of the research constraint is one of the important things. And one more question to both of you. When we are talking of ICP, is ICP the only confounding factor for outcome? I mean, one most important factor, there's so many other factors, because ICP, we have maximum discussion of ICP. Is it the only factor?
No, I think, so again, I'm a pediatric ICU person, and we have some data on kids for this. It seems to, in our database, about 150 kids, the ICP data alone accounts for about 15 or 20% of the outcome. The CP is a little bit less. So I think it's a factor. I think I agree with some of your points. I don't agree with all of them. If you're doing a procedure which you have a 16% severe infection or complication rate, you shouldn't be doing the procedure. I mean, if our infection rates are minuscule, I don't remember the last time we had it, but maybe, I mean, obviously everyone's, reports they have no complications, but so if you have that big a complication rate, then I agree with you that the risks become higher than the benefits, and I think that's a reasonable approach. I think the best trip study, and I just saw Monica walk in the room, so she may know more details than I do. I think what Randy believed to be true when he was designing the study and what he said in public was that maybe all these therapies we're giving are overdoing it, and we're treating numbers, as you were saying, as opposed to treating the patient. If you woke them up and got a better exam, you'd stop therapies and let them wake up and go on. And I think the New England Journal article has spun a little bit out of his control, which is why he's published these other consensus statements and things like that, which is try to get his thing back on ramp. So I think the ICP is a tool. I don't think it's the be-all, end-all. I don't think it's the only thing you should measure. But I think it is a valuable tool if it can be done safely in your ICU. I think it's worth doing, but again, it's my opinion.
Scenario where you would not monitor an ICP.
I'm sorry?
A case scenario where you would not monitor. It's severe head injury. GCS 8. I mean. So in our practice, we monitor ICP on every person whose GCS is less than 8. I think the GCS score alone is not the best way. I think the GCS score plus other variables are going to eventually overtake the GCS score alone. But when we have a GCS less than or equal to 8, we monitor unless the person is basically terminal. If the person is going to die in the next 5 minutes because of their bleeding to death and other whatever, or they've had a long cardiac arrest, and then we may not monitor. But for all intents and purposes, all children we see, children with child abuse, children fall out of trees, children who get hit by cars, children who get hit in sports, if they have GCS less than or equal to 8 and they don't wake up quickly enough for us, they get a monitor placed. Dr. Matthew, a scenario where you would not monitor. I mean, away from your.
Again, away from the debate. Again, the only patients I thought I could not salvage. We would be more generous on our things of not salvaging, because we have limited resources. So if somebody came to me 4x15, just extending to pain and pupils not reacting, I would not put a monitor on him because I don't have the long-term treatment to keep that guy going.
Sure.
So it's a resource-based thing.
And it's also different, and children are different than adults. Children have more resilience and sometimes, can withstand things that adults can't withstand.
A patient who comes with GCS less than 8, we usually talk of post-resuscitation GCS. Okay, so how early would you put an ICP?
That's really an interesting question. And I think I know there's a talk later about the fallacy of the GCS score, and I think the GCS score, which is 40 years old this year, is actually, it's done a disservice because people don't know when. The question is when. And you were talking earlier that people in Delhi get transported to the hospital, it takes forever to get here. In Pennsylvania, where I'm from, it's 200 miles to get to us. And so people in helicopters flying to us. And so they were GCS at 8 at the scene, they got medications, they're now a 4, they come to us again, they're a 10, so figuring out when the medications have worn off, when there's actual stabilization, so it's an interesting question. We don't rush to put to monitors in if we think there's some mitigating factor, but if a kid gets hurt outside of our doorstep, which happens occasionally, and you know their GCS is really a 6, we'll put one in almost immediately. It's a matter of,
So one question. If you're not monitoring the ICP, how frequently do you measure GCS in your ICU? Without an ICP, how frequently do you measure GCS in the ICU?
Matthew will answer.
I can't answer that.
I think he mentioned ICP, so.
I monitor ICP, so I really can't mention that. I can't.
Because this is what happened. Can I just
Mike.
see, the question is not properly addressed. We all know that outcome of severe head injury multifactorial. Amongst the multifactorial outcome, the 2 important factors emerge, which is not contradicted. That is the initial GCS and intercranial pressure. Nobody can contradict the intercranial pressure doesn't determine the outcome.
Prognosis.
First thing. Second thing, GCS. So if we reach the bottom line that 2 single factor which govern the maximum outcome of head injury is the GCS and outcome. Question is that do all severe head injury require ICP monitoring? No. The next question is the ICP beneficial? Yes. So you have to get out those selected candidates when the ICP monitoring helps. It's like intercranial decompressive craniotomy. Is decompressive craniotomy required for all severe head injury? No. Does it help? Yes. Then you have to get out. Gist is that which person does merit a ICP monitoring, right? We do not have class 1 evidence because all the studies are so badly planned that it doesn't result in class 1 evidence. And across the board, whether you start of stroke or you start from anything, there is no class 1 evidence for any disease today in world literature for neurosurgical neurological disease. Is not correct? Okay. I don't know, to my knowledge of 40 years of neurosurgery, that there is any disease for which any treatment given, there is class 1 evidence. Whether you give chemotherapy for glioblastoma or gene therapy for glioblastoma, there is no class 1 evidence.
There's class 1 evidence for
we practice standard of care
TP and
without
stroke.
class 1 evidence. Either the case control studies or level 2 or level 3 evidence. Most of the practices are whether a stem cell or there is instrumentation or removing a lumbar disc has no rationale. So going to rationale has no meaning. Is ICP monitoring has a role in management severe injury? Yes. Should the criteria and the protocol should be designed so that who benefit maximum, we have to design. Otherwise, there will be no debate.
I think there's someone in the back
Yeah.
too.
My question is basically, how does ICP change in those particular patients? Let us say you have 8. Does ICP continuously monitor? Because I think ICP is actually very interesting from biomechanical perspective. ICP really tells you what is the stress and experience by the brain. So higher ICP really means the pressure is subjected to more brain for a longer time, and the diseases are going to continue to happen. That's the way we look at ICP as an important parameter. But the question is, in a severely injured patient, does ICP fluctuate a lot? Is it due to hydrocephalus? What causes ICP to fluctuate? And what do you do when the ICP fluctuates?
Well, there's any number of mechanisms that people think, whether it's swelling or release of radicals or any number of things that could cause swelling to happen. The classical literature has been that ICP increases over the first 3 to 4 days and then it decreases after that. We have some data in kids that shows it actually increases a lot earlier than that and decreases probably earlier as well. So I'm not sure anyone knows exactly the time course for every single patient. I think the most learned person I've heard talk about this is Jeff Manley from UCSF, and he would argue that every patient, if you have an epidural, you have one form of TBI. If you have a subdural, you have a second form. If you have diffuse injuries, so I think we're learning that TBI as a word is not sufficient to describe the patients, and I think they probably have a different time course of ICP, of outcomes, of lots of different things.
So would you change your treatment regimen based on the ICP? I mean, like we talked about a number of 80, 85. So do you go back and completely start changing things based on number, and what do you do? So you monitor ICP.
We use the
so what?
We use
So
our
what do you-
monitor. I mean, we try to mix it with common sense and some clinical care. So that if we have a patient who's GCS, who's becoming more responsive and their ICPs are increasing because they're agitated, we don't treat those. But if a kid who's flaccid and laying in bed, Those ICPs were 15, now they're 35. We think that may be a problem, so we treat those. And so I think there's a nuance between the whole thing. You can't just say it's one size fits all. Hanukkah.
Good afternoon. So I just want to go back to addressing the issue of timing of ICP monitoring, because we don't know when it should be placed, and there's this evolving course of TBI. But and Mike doesn't know this data yet because I haven't sent you the draft paper, but we actually looked at our data for across 5 sites as to when ICP monitors were placed. So I just want to ask the group a question. How many of you think that, let's say, how many of you think that ICP monitors are placed in the emergency department in the US as opposed to the ICU? No one,
No one
right?
bought that one.
No one, okay, so no one bought that one. So actually, Mike, in our series, 24% of the kids in the Pegasus project had ICP monitors placed during their stay in the emergency department, not at your center, but
No
but at other centers. And when we did propensity score analyses and adjusted for the usual things that we adjust for in TBI, earlier placement was actually quite protective. So there may be this component, right, to maybe Randy's study. I'm just saying, maybe one of the reasons Randy's study wasn't, let's say, positive was the timing of placement actually was late in the course of the game. Just a question.
Yeah,
I don't
and-
have the answer.
No, and I think if you leave this talk thinking that ICP monitoring is the only thing you need to do and it's the be-all, end-all, like it has been thought of in the last 20, 30 years, you're probably missing the point. I think it's a part of a strategy to help treat the patients. And if you could do it safely, I would definitely do it. If you can't do it safely, he's flicking me. I'm being attacked. But so
I'm not that violent.
but so I think if you can do it safely, I would do ICP monitoring. I think, people ask the question of the stem cell folks, would you tell your patients to do it? Would you have your family do it? It's like if my family was ill with TBI, I would want them to get monitored if they qualified, if it was in a place that could do it safely.
Thank you for this wonderful and exciting interaction. I think from a neuro-intensive point of view, I'm a neurosurgeon, neurointensivist, and I do face this discussion almost every day. Do we put ICP monitors, or are we doing ICP monitoring? These are, in my mind, 2 different things. The studies, unfortunately, they harp on an ICP monitor and trigger for treatment based on a number. And that messes up all the physiology of an injured patient. Every brain injured is different, and I think to sum up the discussion as to put ICP monitor as a successful treatment, the answer should be no. If you do anything that will allow you, I'm asking you now, if you have a non-invasive technique that will allow you early access to information about the intracranial compartment and intracranial pressure, would that be an equivalent for ICP monitor?
So again, I'm probably biased because I'm a pediatrician. So understanding when a 4-year-old is not responding to you because you're a stranger compared to when he's going to herniate in the next 5 minutes is difficult to tell. And so for pediatricians, I think in this one instance, we're probably more likely to put monitors than not, at least in our place anyway.
Non-invasive monitoring.
I'm getting there. I'm not sure any of the non-invasive monitors, there are monitors to measure the optic nerve diameter, the optic sheath, and there's TCDs as well to look at the velocities of blood vessels. I don't think any of them have held up as well as a direct ICP, to me anyway. At least maybe there will be in the future. Maybe, hopefully, if there be something to take the infection risk and the bleeding risk out of the way, then I think it's a completely no-brainer to look at ICP because it's measuring blood pressure on a non-invasive way. I mean, I think it's completely a no-brainer to do it, but I don't think any of the non-invasive ones have gotten to enough quality yet to justify that.
You're talking about pediatrics, right?
Well, even in adults, I don't think
Because in
anyone's
adults,
really.
I think
The new guidelines, I've been involved with the new Brain Trauma Foundation guidelines, which we published. They're at the journal now, and they took into account Randy's study and put a phrase in about, you may consider not doing it if it was not going to be helpful or something. But I think for the most part, they're going to still recommend ICP monitoring for GCS scores less than equal to 8, adults and kids.
As we evolve in understanding, and both of you eloquently put it, that we have to understand what we're facing, and we're evolving in our understanding of the head injury. I think one of the things that we have to focus on is that the very rise of the ICP is a terminal event. So our focus in the head injury, I think, is that we have to be earlier. Like we have to detect derangements earlier than just the number. When the ICP rises, we act upon it. We have to look into things, and doing a lot of TCDs myself, there are a lot of things that can be changing, flow patterns, flow velocities, and such. And also with the cerebral blood flow monitors and the oxygen tension monitors, there's a lot of physiological derangements that occur before the rise of the ICP. So I think from all what we discussed and the cost yesterday with you, we discussed the cost. The cost is a fact in a lot of the places in the world where a lot of head injuries occur, where ICP monitors cannot be provided. But physiological monitoring can be of help, and I think the more we collaborate and the more we work across oceans and countries, it will improve our understanding together. Thank you very much
Well
for
said.
this.
One final question.
We'll finish.
Yeah, last.
Short
What is the level of ICP you will monitor, you will recommend for surgery in pediatric patients for different age groups? Say
What's the-
infants, what is the ICP you will recommend surgery, decompressive
So in
connectivity
our
in
practice,
pediatric
and this
patients?
is completely just our practice, we try to maximize medical therapies unless someone has an ICP spike which is endangering their lives, which is an ICP spike over 40 or something. So we try to maximize medical therapies by giving hyperosmolar therapies, barbiturates, these sort of things. If it comes to a point where we think they're gonna, have a herniation event, we go to OR, we go to the operating room quicker. If it comes to the point where we think the medical therapies aren't going to work anymore, we decompress them at that point. It's still a mixed bag.
So can we extrapolate the adult thing to the pediatric thing? That is what I was asking. The
I don't
pediatric
think you
patients
can-
are probably
I don't
different.
think so.
So probably we'll have to operate at a
think
low
so.
ICP. So what is the threshold that you like to operate?
I just told you that I think if we have a patient who we think is going to herniate in front of us at that given second, we'll take the person to theater and take their skull off. If we come to a point where we can give medical therapies to try to temporize things, we do that. If those end up being exhausted, we go to other extreme measures, and surgery is one of those things.
We'll conclude the discussion here. We had a very interesting discussion. Rational use of ICP. Even if many centers don't have it, clinical monitoring with radiological monitoring is effective. And as Dr. Michael told, with every value, we have to use our common sense. Thank you very much, and join for lunch.
you.